Good morning.
Good morning.
Oh, I love that background. It looks so nice and cozy.
Oh, thank you.
With the greens in the background, the flower, the plant. I love it. I love it. How are you?
I'm great, and yourself?
I'm doing. I'm doing. We just started a new semester, so I'm doing.
Okay.
I'm doing. Ah, how's your week been?
Oh, it's been weekend.
Can you say that loud for the folks in the back? Because Jesus, I don't understand. I don't
It
understand. It's about to storm outside. That's why I keep looking out the window like, oh,
really? It's cool here. It's in the 60s.
it's cool, but it's dark. I mean,
Oh
literally,
wow.
it's dark outside. It was light, and now it's dark. It looks like it's about to let loose some storms. So if we be hearing thunderstorms, look, hopefully, Spectrum. We have no paid advertisers here, but other than PRN and the coding nurse. But hopefully, hold on, Spectrum, hold on. Oh, but that it seemed like another month of Sundays. Are you gonna be able to do the meeting after meeting? Because I got a couple things I want to run by you. No.
Actually, not for
Okay.
like the next 2-3 weeks.
Okay.
I got stuff going on.
Okay. Well, I'll connect with you maybe
Okay.
sometime this week. Just to yeah. No worries. No worries. Well, it'll be a quick session unless they talk me down. Even though sometimes they do talk me down, I'll be like, oh, well, wait a minute. Since we talking about this, because we'd have been all over the world in the meeting after the meeting. All right, all right. Well, let's get this party started. Welcome to the Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss health information, news, education, how weeks are weekend, the weather, our meetings after the meeting, which are fun and lively, certification tips and entrepreneurship, and really the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the Girl with the Pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. And let me ask, do you know what it takes to be a certified marketable medical coder? Do you? Well, before I introduce my co host, let me share with you information on a free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. I'm looking at that picture like, where them pearls at? I need to pull them pearls out of the closet, out of the crates, like I like to say. All right. So if you are interested in getting more information about the 5 steps to become a certified marketable medical coder, check the video description for the link. Joining me today is my partner in success, my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been in healthcare for a very long time. In 2014, I left the bedside and switched into risk adjustment coding. Since that time, during the pandemic in 2020, I created a company called the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
Okay, and how is that working?
It's coming along.
Okay,
I,
wait a minute. Time out. Because when we got the full view, I'm like, okay, I see coding books and stethoscopes. You better come through. You better come through with the combination of the coding nurse. I love that. I love that. Did you do that? Did you do that?
yes.
Yes, I love that. All right. Okay, go ahead. I'm sorry.
Thank
I just got excited.
you.
You know me.
So it's just I don't know. From the coding nurse perspective, I keep having the same conversation over and over and over, and it's like you have these specifically for nurses, and it's what we talk about all the time. Like I just don't know, like these people, like self-study just is not the move, and I don't know why it's not. I mean, I don't know because I've never done at the AAPC CPC program. So I don't know what they teach or what they don't teach, but I just know, and also a HEMA, because that's just was corresponding with the nurse over the past couple of days. She did the HEMA self-study and stopped. It's just I don't I just feel that at least for ICD-10 CM, it is too many twists and turns. Like you need somebody to explain it. The procedures, I think you can kind of get through. I think you really can. But ICD-10 CM, I think you need to be taught. I just because it's the same conversations all the time.
I think it's a combination of the student because you got to have a certain mindset to, like you said, finish a self study, but you also have to have the environment that's conducive to that. You have to. It's a lot of planning. It's a lot going on with a self study. I've taken a self study. Not it was something unrelated to health information, but so because it was unrelated, it was unfamiliar territory. Now, something in our field, we can root right through that. But I was purposeful in doing something that was unrelated. And so you really have to take time to get in and understand and read. And you're right, you do need to have somebody somewhere that can answer your questions or assist if needed. But you gotta know that this is a self-study class. You signed up for whatever this is. It's asynchronous. It's just going to be the material or the information. Prayerfully, you have some narrated lectures or something, and it's interactive so that you are getting that kind of back and forth, able to learn. If it's just here goes some chapters, read this, do this, take a test, that's hard. That's difficult. Probably in any field, but particularly in this, because you're really learning a skill. And I think for me, when trying to get the skill out, you have to show. Like you have to show, be it in person or asynchronous. You have to show because they are especially if it's brand spanking new to you, they're clueless. They don't even know what to do. Like you really have to have let's open the book together. Let's take a look at what these things are. Here in the front cover, you'll find da 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 da. Here in the introduction, you'll find da 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 da. Like really prepare them for that. And I don't know if taking the time to set that foundation actually happens in some of these self-study type of things. I think it's more, oh, well, we think you know enough. Let's just go. Here's an introduction. Here's a quick da-da-da and go. And then the assumption is you got it. So we're just moving on. And I think that's where some of that hits. So if you don't have someone that you can tap into, and I thought there was, for additional fee, at least with the AAPC, I thought that was available to them, that you can have somebody or something. I don't know. I believe that at some point that was the case. Like you can get this plain regular self-study by yourself, or for an additional,
right.
You can have somebody. But then I heard that there were like some conversations about the somebodies.
Right.
And
Right.
the accuracy of the information that the somebodies were providing. So I don't know. I just when I was doing I used to have a monthly kind of Q&A thing, And it was really helping you vet wherever it is you go. Like, of course, I want you to come to me, but if I'm not your girl, vet the people, vet what, and so I was giving like some tips on how to vet these people to make sure that what especially in today's economy, it is dark, especially in today's economy. I'm nervous, especially in today's economy. Coins are important. Coins are coining, and you really want to make sure that you're not wasting your money or you're not getting something that, yeah. So I just there was maybe I need to revamp that. Maybe I need to put together maybe a talking point or something. Look, everybody doing these AI graphics. Maybe I need to do one of those. But something that, vet the people, vet what they're providing, vet who's providing, vet what you're supposed to get, vet what the outcomes are, vet all of the things. And then shop around. Don't just be like, okay. And I get, you like what you like, and that's all great, well and good. But at the end of the day, you got to be okay with what it is that you paid for. And just jumping in and saying, okay, I'm gonna do this, and then you mad at the end. Well, you're a consumer. You got to treat this as a consumer, because you can find people left and right. We do it all the time.
And what I also think is, and this is what we have been saying for the longest, I just think even our industry, but more importantly, I think people, when they get into medical coding, they have no respect for it. Like, people will think that anybody who can program in SQL and Python, like, they think they're geniuses, but they don't think that people who do medical coding that is directly responsible for billions of dollars in revenue, they don't think that we're geniuses. Because then what happens is, see, you can go on ChatGPT and get SQL scripts. You can get Python scripts, because those scripts don't change. The syntax doesn't change. It was the same when it was created as it is today. Coding has too many caveats. Too many. And you have too many people who say that, oh, well, I Googled the answer on ChatGPT. You can't Google medical coding on ChatGPT, because
when did that come out? What code? What year was that? What you?
And it depends. You would have. I mean, it just
what guidelines have changed?
Exactly.
Yes.
And I just think that's the disconnect, because even people who self-study computer coding, you can use ChatGPT or some kind of large language model as a resource. But medical coding, you're asking, and because I've even tutored people who said, "Oh, well, I Googled I ChatGPT'd this answer and it was wrong." Of course, it was wrong, because it doesn't have the context.
And then my thing for them is, so you recognize that it's wrong. Reverse engineer that. Why is it wrong? Tell me why is it wrong? Because that's going to get you to think. That's going to get you to put in some of those critical thinking. Okay, well, let me kind of go back and look at what the guidelines say, or whatever. That's the thing. That's the other piece of it that they got to have.
But that's it, though, because the thing is, they can't figure it out because they don't know the guideline. When I tell people all the time, medical coding comes down to guidelines, period. When you take those exams, they test you on the guidelines, period.
That's what they're testing you on.
And if you don't understand the guidelines, you will never pass, and you'll never be successful as a coder.
Yep.
You have to master the guidelines. Have to.
Yep. And not memorize, master.
Oh, no.
Because it could be here today, gone tomorrow. But master. Look, we done took a whole different turn. Look, this should have been a whole show right here. Maybe we'll do a part 2. This could be the next show. Because you're absolutely right. And you've mentioned that before about, and I'm writing this down for show topic, the disrespect and disregard of medical coders. I like that. Okay, sorry. But yeah, I don't know. It's just, I don't know. And then you got to think about the people, because I promise you, if I hear one more time, I just want a job where I work from home, I'm gonna scream. I swear to God. I mean,
Listen.
literally, I want to stay in healthcare, but I don't want to be at the bedside, which I had that was my same mantra. Like, oh, even though, folks have told me as of late, oh, you would have been a great nurse. I probably would have because I do care about the people I'm caring for. And I would care about patients and I would, but at the time when I was coming up through the school, mm. but but I love and that's how compliance got me because I love the intersection of medicine and law. I love that. And so that's where compliance feeds me. But health information fed me first, specifically coding, because I'm like, wow, this is fabulous. It's a puzzle. You got to figure this out. You got to know the pieces. You got to know where to go. You got to know, all of the things. And so it's like a real good book. Now, inpatient coding was something totally different because I was like, how many more pages of this I gotta read? It was a lot. So the physician side was, we hit it and quit it. And I was all in. All in. But I just it never was it a thing of, oh well, I just, whatever the least resistance or whatever the low hanging fruit that I can get into the health. We are not the low hanging fruit to getting into healthcare. I think if and once they get in and learn, of course they get the big eye like, I didn't know. Yes, this is not to be played with, sweetie. What you do impacts a whole lot of things related to the operations of all of these healthcare facilities, and we the front. Well, we're not the front line because those folks at registration are the front line, and what they do is key too. But we close too. We got a whole bunch of skin in the game as it relates to that revenue cycle on front and back ends.
But until I got into HIM, I had never even heard of the revenues as a concept, the revenue cycle. And because in nursing school they don't teach you about insurance, reimburse, none of that.
Yeah, medical school either. They don't.
Exactly. And it's like, and I get the focus, but it could at least be like in your last semester, have a conversation about the concept of healthcare and the part you play in it, and talk about how all of these things come together. You don't have to know chapter and verse about what the front end does and the back end, but you at least have to be aware of it and how it and how what you the part you play in it and how you affect the whole cycle. And go ahead.
Go ahead.
And I think that's why when nurses come to me, they have no clue. Like I had somebody this week, I want to get into nurse auditing. Okay, well, what do you want to do? Inpatient? You want to do outpatient? You want to do a specialty? I had no idea that it was that big.
It's different. And I know well, aside from that, trying to combine some of the coding roles where they can do both, but I don't know about that. That's another conversation. A whole other topic. But what I was gonna say, when I worked at an academic medical center, and it was amazing to me that that's how I know physicians aren't getting this information either in medical school. Only when they were coming into their residency or almost done with their residency did we created a whole class just for them to talk about, what the impact of their documentation is as it relates to the revenue cycle and compliance and all of those things. And it wasn't a mandatory class for them. It was kind of optional if you want to come in and get, and we would really get those who were looking to go into private practice, because they were like, oh, I need to, they was all in. Like, how do I know and make sure, this is right, and I don't go to jail and they don't take my money, and so they were all in. But there should be some sort of, to your point, introduction to healthcare more than just what you're going to do at the bedside. Like how what you do at the bedside is impacted by so many areas, particularly your documentation. Good Lord. that in and of itself. And I think nursing, at least my understanding of nursing education, y'all some sticklers about the documentation, because we used to say, just go look at the nurse note. What does it say?
Right.
Good Lord. Because, yeah. So, yeah, I think we
Look,
got two topics out of this whole little conversation right here.
we done ran on a tangent, but I got another story, but I want to save it for my church announcement.
Oh, okay. All right.
You'll like it. It's a compliance thing.
Cool. All right. Yeah, we have gone above and beyond. All right. So remember that you can join in and add to the conversation. So don't be shy. Your opinion matters and is welcomed here. So use the chat. Again, if you have a question for us, just put Q first so that we know it's a question for us and we don't miss it and it's not something that gets shuffled. They did something with StreamYard is always doing something. So now it'll let you know that you've shown the comment, so you don't re-show the comment again or something. I said, well, come on.
Okay.
Yeah, they doing all kinds of things in here. All right. Good morning. Hi. I had a question for you. I don't know if you coming in on the meeting after the meeting, but I had a whole question for you that you're gonna chuckle at. All right. Oh, it grays it down. Okay, I see what they're doing.
Okay.
Here. Look,
well, that's good.
Okay. You only get to play when we on live or if we have the meeting after the meeting. All right. So for those who are just joining us or watching the replay, we done talked about a whole bunch of things. We done dropped all kinds of gems today. But specifically, our topic is about sepsis coding, the sepsis coding crisis, and what every coder must know. And I think we talked a little bit about something related to this, but it has gotten completely out of hand now. But anyway, but first, we have our church announcements. So let's get right into those quickly. Hey. Yes. That's when you need I'm gonna get the tambourine. I promise you I'm gonna have a tambourine over here. Be like, ma'am. I know I went to when I was in Richmond and we were at the ball, there was a group that had their tambourines with line dance, and I was like, y'all better come. Oh, I said, yes, that's what I need. That's what I do. I love it. All right, so real quick, my church announcement is around the AMA versus AI deepfake physicians. They done changed, redirected some of their energies. You know how they are it's always been the physician or AMA versus somebody. Well, now they are talking about these AI deepfake physician impersonations, and they have put together a whole, there was a lawsuit over an AI chatbot that was presenting itself as a licensed medical professional. That's one
here in Pennsylvania.
That was the one issue. But the AMA also is putting together like a whole framework around on what this looks like, and their 7 policy principles are physician identity as a protected right, prohibition on deceptive medical impersonation, informed, opt-in, and revocable consent, mandatory transparency and labeling, shared responsibility to prevent impersonation, enforcement and practical remedies, and minimizing administrative burden. They always got to slide that in. So those are the things. So I was like, and they use the term augmented intelligence when referring to You know they gotta be special with everything.
Always.
So that was my church announcement. Be on the lookout because when the AMA comes for something or somebody, they come. So you probably see a lot of information about that. Mr. Jesse, what's
Well, my church announcement is going to be brief, and it's going to start with all money ain't good money.
Okay now.
So I got contacted on, of all platforms, Facebook, from this lady who had reached out and said that she was working with a small group of pharmacists who were coming up with a new drug for heparin-induced thrombocytopenia.
Okay.
I'm like, okay. And it was mainly, they wanted to mainly focus on cabbage procedures. So after first I thought it was a presentation and they said something about like an honorarium. So when I responded back, it was like going into the weekend. So I think it was Monday, she reached out. And as she started talking, I'm like, wait a minute. I said, this does not sound like a presentation. This sounds like a consultation. So she said that they wanted me to basically code a scenario that they had for this, for this new drug for heparin-induced thrombocytopenia. Then they wanted me to do a 30-minute presentation on it. So I'm like, first of all, like, what? Oh, and then they were like, well, can you do it in 2 days? No. And then I asked, I said, well, I'm going to need to know what established sources you use to validate the condition that you coded. Well, it done went radio silent. I ain't heard from her because because my spidey senses was already tingling because these are the kind of people, because what they do is, because I've seen it done before, they get somebody to say these are the codes that you use, and then it will be in their marketing material. And when they go to these physician offices, get them. These are the codes that you use. No.
Yeah, because I know. It's Johnson & Johnson. Johnson & Johnson. Yeah, because they have. I think it's still office here. There's an office here, locally, and there was. I didn't work for them. I had a friend that worked for them, but they brought me in to help do something with her. I remember doing something with her, but that's what her job was, to help them prepare the materials that they were taking out in the field and validating. They had a whole little department to do that, to validate like what the codes were, if there were surgeries involved with some of the, because some of it was on the pharmaceutical end, but some of it was on the medical device end. And so, what types of surgeries would they use this machine for, device for, and these are the codes. So yeah, they had a whole area. That's a whole thing. But yeah, it would go out to their in their stuff. And would there even be a line credit to the person who put the stuff in? Probably not. That's crazy. Well, that part too.
And that, but what it was for me is like, first of all, like that's not an honorarium. Like, we need to be discussing a rate. No.
Back to all money ain't good money, huh?
There you go. That's all I got.
Cool. That's funny. Okay, let me stop the banner. All right. So let the tea spilling begin. So again, good morning, and welcome back to the Saturday morning tea, where we serve up the real talk our profession needs. And we've been talking. We pour up something warm, something real, and something that genuinely matters for your career in health information, medical coding, and or compliance. I'm Clarice Warner, the girl with the pearls, with my partner in success, the coding nurse. And if you're new here, welcome. We meet every Saturday morning to demystify medical coding, billing, and everything that keeps healthcare revenue flowing and talk about the things in healthcare that actually matter for your career, your compliance, and your coin, your paycheck. And to my returning friends, again, thank you for being here. So get your cup of whatever it is that you're sipping on, no judgment here, and come on in the room. Cup, glass, whatever. So today we're talking about sepsis and what every coder must know now. So what do you do when the coding system you rely on every single day no longer matches the clinical reality your physicians are living? Okay, this is not a hypothetical. This is exactly where we are right now with sepsis. And like I said, we talked about this, it's been some months when there was some first rumbling around what's happening. Well, the rumbling is erupting. And we really just want to um, talk about what's been kind of 10 years in the making, because this has been going on for a while. So we're talking about sepsis, and not just as a clinical condition, because we know sepsis is the body's extreme life-threatening response to infection. Today, we're talking about a fundamental structural problem inside ICD-10-CM with the International Classification of Diseases, 10th revision, clinical modification. That is costing hospitals millions of dollars, creating documentation chaos, and leaving our coding professionals caught between clinical reality and outdated classification systems. Mhm. And here is the good news. Right now, in May 2026, right now, the window to help fix it is officially open. So again, pour that cup, pull out a notepad, and let's get into it, because it can all be so simple. And together, we're going to make sure that it is. So let me set the stage, and Mr. Jesse, jump in with some important history, because context is everything in this profession. So to understand why this matters today, we need to go back all the way back to 1992. So in 1992, the medical community adopted what we now call Sepsis 1 and Sepsis 2 terminology. And under that framework, sepsis was defined as SIRS, which is systemic inflammatory response syndrome due to infection. SIRS is the body's widespread inflammatory response, things like fever, rapid heart rate, elevated white blood cell count. Importantly, under Sepsis 1 and Sepsis 2, you could have sepsis without any organ dysfunction. And if organ dysfunction was present, it was called severe sepsis. These were two distinct clinical categories. So when the CDC, which is the Centers for Disease Control and Prevention, modified, this is way back, ICD-9 CM in 2003, it reflected that Sepsis 1, Sepsis 2 framework. And when we transitioned to ICD-10 CM, we carried that same structure forward. So today in your coding manuals, you have codes A40 and A41, sepsis without associated organ dysfunction, and code R65.20, severe sepsis, for sepsis with associated organ dysfunction, usually reported alongside the A40 and A41 codes. Now, that structure made sense in 2003, but then came 2016. In 2016, the Society of Critical Care Medicine, or SCCM, and the European Society of Intensive Care Medicine, ESICM, completely overhauled global sepsis terminology in what is now called Sepsis 3. So under Sepsis 3, the definition changed fundamentally. You cannot have sepsis without organ dysfunction, period. Organ dysfunction is now a requirement to diagnose sepsis. The term severe sepsis was rendered clinically obsolete because under Sepsis 3, if there's no organ dysfunction. You simply have an infection, not sepsis. So, Sepsis 3 also introduced clinical tools to operationalize that definition. For adults, the SOFA score, which is the sequential sepsis related organ failure assessment, and an increase of 2 points or more signals organ dysfunction consistent with sepsis. For septic shock, the criteria include a vasopressor requirement to maintain a mean arterial pressure of 65 millimeters of mercury or greater, and a serum lactate level greater than 2 millimoles per liter, in the absence of hypovolemia, meaning low blood volume. Now, for our pediatric patients, because sepsis in children requires special attention, the world was waiting for an updated framework too. And in January 2024, the CS, the C, the SCCM Pediatrics Sepsis Definition Task Force released the Phoenix criteria. So, like Sepsis 3 for adults, Phoenix requires organ dysfunction due to infection to define sepsis in children from 38 weeks of gestation all the way through age 18. And just like Sepsis 3, Phoenix rendered the older 2005 pediatric sepsis criteria and its concept of severe sepsis obsolete. So here is where we have been stuck. Clinicians and critical care medicine moved to Sepsis 3 in 2016. The CDC and ICD-10 CM did not. So CMS largely, oh, they didn't follow either. And the result has been a decade of misalignment, denials, disputes, audit risk, and coding professionals caught in the middle. And this is where things get very exciting and urgent, because earlier this year in March, specifically March 17, 2026, the ICD-10 CM PCS, of course, that's with the procedural coding system, Coordination and Maintenance Committee. Remember, we talk about their meetings all the time. If you ever need some free CUs and got some time on your hand, go listen to their meetings live. You get some free CUs, but that's an aside. Presented an initial proposal to finally restructure how ICD-10 CM handles sepsis. So this is the beginning of what could be a historic correction, and we can all be part of it. The proposal has three main components. So let me walk you through each one carefully because each one of them impacts your daily work. That's right. First change is to eliminate code R65.20, which is the severe sepsis. So under the proposal, the concept of severe sepsis as a standalone codable condition would go away. Why? Because again, under Sepsis 3 and the Phoenix criteria, all sepsis already requires organ dysfunction. So there's no sepsis without it. So the modifier severe becomes not just redundant, it becomes clinically misleading, and we cannot afford misleading encoding. Proposed change number 2 is new Chapter 18 codes, specific organ dysfunction associated with sepsis. So in place of that one broad severe sepsis code, the proposal introduces new codes that capture which specific organ systems are affected. These would live in Chapter 18 of ICD-10 that signs, symptoms, and abnormal clinical and laboratory findings. And they would include R65.220, respiratory dysfunction associated with sepsis, R65.221, coagulation dysfunction associated with sepsis, R65222, liver dysfunction associated with sepsis, R65.223, cardiovascular dysfunction associated with sepsis, with an excludes note for septic shock, R65224, central nervous system dysfunction associated with sepsis. Now, think about what that means. Go ahead. I see you raising.
But yeah, I just wanted to. I don't know whether they they left the code out, but the Sepsis 3 and the SOFA score has 6 systems. That's only 5. They left out the renal because you can also they also check your creatinine level. So I don't see a code for for renal disease.
Why would they do that? Well, that could be something that could be added to the comments when the commentary. That's interesting. Okay. So now think about what all of this means. So instead of a one catch-all code, we will need precise, specific documentation from our physicians and providers about which organ systems are affected and that those dysfunctions are linked to the sepsis diagnosis. Again, this is a documentation game changer. Proposed change number 3 is impending sepsis, which is a brand new coding concept. So this one is truly new territory. The proposal introduces the concept of impending sepsis into Chapter 1. That's certain infectious and parasitic diseases. The proposed code is A41.92, impending sepsis, unspecified organism. This code could be triggered by a positive sepsis diagnostic aid, meaning an early warning tool or screening result, even before a patient fully meets sepsis 3 or the Phoenix criteria. So think of tools like IntelliSep or Immunoscore or Triverity or the EPIC sepsis model. These are all AI-driven and laboratory-driven early detection systems designed to flag patients at high risk for sepsis before organ dysfunction is established. So the idea is that if we can code impending sepsis, we can support early intervention and ideally prevent full sepsis from developing. So let me be clear. The CDC has emphasized that the March proposal is preliminary. A more complete proposal will be presented at their September 2026 meeting after public feedback is received. And that feedback deadline is August 15th. I'll come back to that in a minute. So let me break down what all this means for us, the professionals doing this work every single day. For medical coders, your current instructions are solid, but change is coming. So right now, under current ICD-10 CM guidelines and coding clinic guidance from the fourth quarter of 2016 and the fourth quarter of 2017, coders are instructed to assign a sepsis code when a physician has diagnosed, documented, and affirmed sepsis using whatever clinical criteria the physician deems appropriate. That's the rule. We follow documentation, period. But when these new codes go live, you will need to assign organ system specific codes, which means the documentation you need from physicians must be far more specific than it is today. So again, it's not in the rules yet, but you may need to have these conversations and start preparing folks for what can be coming down the pipe. Go ahead.
Even like right now, like with R65.20, when you go to the tabular under the R65.2 subcategory, it's a whole lot of instructional notes. And you already have to use organ codes. So I just think that with this is going to create more problems because as it is now, you have to already say they already have to associate for severe sepsis. They either have to document severe sepsis or have an organ dysfunction associated to sepsis. So if they say, liver failure secondary to sepsis, that's already included. Because that's already in, and that use additional code part of the R65.2 subcategory. But with these codes, with these expanded R65.2 codes, will you still have to name the specific infection, the specific dysfunction? Because it could be like coagulation or liver dysfunction. Okay, but that's kind of
broad,
because you only have one liver. But coagulation, because these are all based on like specific, they are specific organs, but there's a lot of different. There's moving parts because like coagulation is based off of platelets and the liver is based off of bilirubin. And then what also happens is when you go to validate sepsis, if somebody already has a condition that affects that system, you can't include it. So if somebody may have severe sepsis, but if the provider says, "Oh, well, this person has acute respiratory failure due to sepsis, but they also have pneumonia," you can't count that.
Right.
So I just think they're gonna have to do a lot of education
A
for
lot
these
of education. And like
for,
I said, this is just the preliminary piece. They still have another proposal, I guess, coming, because they're, when I get back to the August 15th date, they're going to take into consideration the comments from folks. And yeah, the all of this could potentially change or expand. And you're right, the education piece is going to be huge, which however they move. But it seems like they do need to move in some type of direction. And after folks consider or hear the information and consider, there may be a whole different direction that they may be going in. But at some point, they need to be current with the way sepsis is being clinically evaluated, and not just, ICD-10 needs to change at some point, somehow, with guidelines or something. Something needs to they need to line up and match.
Oh, I definitely agree, but I just think that this, and then that whole like impending sepsis, that's going to be a problem.
That's because everybody's interpretation of that. Yeah, that's gonna be an issue.
Because I just think you're gonna have to have some very, very clear criteria. And
Absolutely.
I mean, and I don't know, because I'm not a physician, but maybe, and then because what also is interesting with this whole SOFA score is that they don't include, when you go to validate, facilities and a lot of payers will include um blood cultures, but they never talk about blood cultures, because chances are, if you have positive blood cultures, you really have sepsis, like
Hmm.
in the purest form. Now, maybe it also goes hand in hand. If you have positive blood cultures, you also have some kind of organ dysfunction, which very well could be.
Could
But
be.
I'm just wondering if there are instances where somebody does have positive blood cultures, but they don't. Well, I've already answered my own question,
You
because
did.
you only get 1 point for a
Correct.
positive blood. You still need two, so you still need
Correct.
something else.
You got
But
something else.
okay.
Yep. So for our CDI specialist, your query strategies must evolve. So if severe sepsis is eliminated as a concept, a query that simply asks, does this patient meet criteria for severe sepsis, will become obsolete and potentially non-compliant. You will need your physicians to specifically document which organ dysfunction is present and explicitly link it to the sepsis diagnosis. And this is a fundamental redesign of your query toolkit. And you need to start planning for it now, well ahead of the fiscal year 2028, or, yeah, well ahead of that. Even though there's some grumblings about the whole query framework uh, updates too, but that's a whole other conversation. the the Medicare Advantage denial problem is also real, and it's been going on for years. So Medicare Advantage, or MA, and managed care Medicaid plans have been denying sepsis related DRG payments based on sepsis 3 criteria for years. That's where we keep hearing all of this stuff. So while traditional fee for service Medicare maintained the older framework and actually prohibited its accountability agents from denying sepsis DRGs without an associated organ dysfunction, a DRG, or diagnostic related group, is how hospitals get paid for inpatient stays, for those who don't know. That inconsistency has made sepsis one of the most contested areas in clinical validation denials across the industry. So once ICD-10-CM aligns with sepsis 3, then payers will then have less ground to stand on. But until then, your appeals process and clinical validation documentation must be airtight. Also, the impending sepsis code raises critical compliance questions. And here's where I want our compliance officers to pay very close attention. If a positive sepsis screening tool can trigger an impending sepsis code, does a coder assign that code based solely on a documented positive test result? Or must the physician explicitly document the diagnosis of impending sepsis in their notes? This is a question that the CDC has not yet answered, and the answer will have enormous compliance implications. Think about how COVID-19 test positivity coding worked during the public health emergency. There are parallels here. We need that guidance before implementation, and we have time to make sure that we can get it. Present on admission indicators will get complicated. POA, or present on admission indicators, exist so payers and quality programs can differentiate conditions that were present when a patient arrived versus those that developed during the hospital stay. The new coding framework creates some thorny POA questions. For example, if a patient presents with impending sepsis and then develops full sepsis 3 defined sepsis during the admission, what is the POA status for the sepsis code? Yes or no? And for septic shock, if a patient has sepsis on admission and develops shock during the stay, current guidelines require reporting one code with a POA of no or N. These issues must also be addressed in updated official guidelines before any of these new codes go live. Also, the ripple effect is enormous, and this touches everything. So again, this is not just a coding update. Every system that relies on sepsis coding will need to be reconfigured. We're talking about MSDRGs, the payment groupings for traditional Medicare, APR DRGs, the all patient refined diagnostic related groups used by Solventum for severity of illness and risk of mortality assignments, the SEP1 core measure, the severe sepsis and septic shock management bundle, which is a CMS quality metric, patient safety indicators or PSIs, including PSI-4, the death rate among surgical inpatients with serious treatable complications, and PSI-13, postoperative sepsis, the Yale CORES mortality and readmission measures, and quality algorithms used by Vizient, Premier, and others. So every one of these will need to be re-examined and realigned. The ICD, go ahead.
Because speaking for MSDRGs, because like the whole APR DRG, like that matrix, that's a lot. Like it just depends on what else they got going on. But for Medicare, they will probably just eliminate DRG 872, which is just plain sepsis. So if they're saying that you can't just have plain sepsis, then you would have it would just be 871 and 870, because 871 is with the CC or an MCC, and 9 times out of 10, an acute organ dysfunction is going to be an MCC. So.
And then ICD-10-CM must also address elevated lactate coding. So here's an important technical point that Dr. Kennedy, who this article that we're discussing came from, raised in the article. Right now, ICD-10-CM classifies elevated lactate, key sepsis indicator, as unspecified acidosis, even when full metabolic acidosis criteria are not met. So the SEP1 measure considers a lactate level greater than 2 millimoles per liter in the setting of Sears criteria as evidence of severe sepsis, unless the physician documents another cause. Things like metformin use or thiamine deficiency, end-stage liver disease, or malignancy. ICD-10-CM needs a dedicated code for elevated lactate without acidosis. And the proposal suggests something like R79.84, which would read abnormal findings of blood lactate. And our physicians need to be engaged to document the differential diagnosis of lactate elevation, distinguishing between type A causes, which involve tissue hypoperfusion, and type B causes, which do not. So, I want to leave you with some thought-provoking questions, as I always do. And these are for you to reflect on and honestly to bring you back and bring back to your teams or have these conversations. So, question one, if the concept of severe sepsis is eliminated from ICD-10-CM, how will that change the way your facility documents and codes sepsis today? And is your team prepared for that transition? Question number two, right now, your coders are required to code sepsis when a physician documents it, regardless of whether sepsis 3 criteria are explicitly met. But payers are denying based on sepsis 3. So how is your compliance team navigating that conflict? And what does your appeals process look like? Question three, the proposed impending sepsis code could be triggered by AI-driven tools like Epic Sepsis Model or IntelliCept. Should an algorithm result without explicit physician documentation be enough to support a coded diagnosis? And where do you stand on that? Question four, with organ-specific dysfunction codes replacing one broad severe sepsis code, CDI query strategies will need to be completely redesigned. Does your facility have the clinical and educational infrastructure to support that level of physician engagement before fiscal year 2028? And question number five, as a coder or CDI specialist, what is the one change in this proposal that you believe will have the greatest day-to-day impact on your work? You can drop it in the comments. I want to hear from you. That will be interesting to know. So this is the part of the show where I need you to lean all the way in. This is the whole call to action because it could all be so simple, but only if the right people take the right steps at the right time. And we are those right people, right? Right. If you want to walk away from this episode with a clear, concrete, well, I want you to walk away from this episode with a clear, concrete action plan. So let's go through it together, step by step. Step one, submit your comments. You individually, you can submit your comments to the CBDC by August 15th, or you can get a team together, or you can sign in. I believe AHIMA is possibly, if they have it already, or commenting on this. So you can jump in on various task force that they may have. But you individual can say, you know what, this doesn't make sense, This is what I think it should be. You have the right. You're an expert. Make a comment. So anyway, write in your calendar right now, August 15th. Do not let that date pass. The email address is nchsicd10cm@cdc.gov. Yes, you do not have to write a legal brief, not at all. Just tell them what you see every day, how sepsis denials affect your facility, what the documentation gaps look like on the ground, what happens when coding guidelines do not match clinical reality. Your real-world perspective is exactly what the CDC needs. And it is the most powerful thing you can offer. You have the experience. You're in the trenches every day. You are on the front lines. Let them know. Pop out and tell them. Step two, engage your professional organizations. Again, whether you are an AHIMA member, an AAPC member, or active with ACTIS, which is the Association of Clinical Documentation Integrity Specialists, contact your chapter or national leadership. Encourage formal comments to be submitted. I do believe AHIMA is already on this. I'm not certain about AAPC, and ACTIS may be involved too. But reach out, find out, go to their website and see. And usually it's around their advocacy efforts. So take a look and see what they got going on. But you can encourage formal comments to be submitted and ask how your organization plans to respond to this proposal. Your membership dues work harder when you use your voice. Step three, support the Sepsis Alliance at sepsis.org. They are taking a meaningful leadership role in negotiating these issues with the CDC. Their Unite for Sepsis meeting is coming up in Washington, D.C. on June 11th and 12th. If you can attend, go. Register at uniteforsepsis.org. If you cannot attend in person, just visit their website and share their work, and consider reaching out directly to show your support or get a better appreciation and understanding of what is included in this advocacy effort. Remember, patient advocacy and professional advocacy go hand in hand. Step 4, start educating your physicians and clinical teams now, not after the code drops. You have some pre-work. You got they dropping some gems so you can prepare early. Even before final guidance is released, your hospitalists, intensivists, pediatricians, and obstetricians need to know that the landscape is shifting. Host a lunch and learn. Share this episode. Print the proposed code list. The earlier your clinical staff understands Sepsis 3 documentation requirements, the smoother your fiscal year 2028 transition will be. Smooth transitions start with education, not emergency retrofits. Remember, be proactive, not reactive. Step 5, and the last step, mark your calendars for the CDC's September 2026 meeting. That is when the full revised proposal will be formally presented, and that is when the real momentum begins. You can also subscribe to the RAC Monitor and follow for updates, because they will definitely keep us abreast of what is happening, both from the professional side, but also from the clinical side. Follow your professional organizations, stay in the loop, and you can always stay connected right here with us on the Saturday Morning Tea, because we will be covering this as developments unfold so that you can stay in the loop as well. All right, so I want to close with this. Sepsis is one of the most clinically complex and reimbursement sensitive conditions we navigate in this profession. It touches MSDRGs, risk adjustment, quality measures, clinical validation denials, and compliance, all at the same time. And the stakes for patients, for providers, and for our profession have never been higher. But here's the truth I keep coming back to. The people in this community, the coders, the CDI specialists, the compliance officers, the health information professionals, you are the ones who hold the system together. And you are the bridge between the clinical medicine and reimbursement, between what physicians document and what the data shows, between what the guidelines say and what actually gets coded and billed every single day. And that is not a small thing. That is everything, right? Right. We are the ones. And right now, in this moment, the door to influence the system is open. The CDC is listening. The comment period is live. And this community has the expertise, the credibility, and the experience to help shape what comes next. So, Mr. Jesse, do you have any closing thoughts?
No, this was a good topic, and I can't wait to see how it all shakes out.
Yeah, because we're gonna definitely have to do a follow-up after that. I need to put that on my calendar because I'm gonna be at that meet, the CDC meeting, because those are great meetings. They're actually really, really good. If you ever get a chance to go to the coordinating and maintenance committee meetings, where they actually just walk through all of the different changes, and they have a clinical person kind of talk through what their thoughts were, or what their interpretation of what should be or should not be in ICD-10 and the guidelines. And then you have the folks who actually are part of the cooperating parties kind of give their spiel on if this could or could not could happen. And then you also have those who are on the who are attending, and then they would give, I understand you want to add a dot here or a question mark here or whatever here, but how does that affect this particular set of codes? Sometimes people don't realize what the changes that they're making, how it impacts other areas in the code book. And so, folks will bring that up, and then that changes the whole dynamic. And then, they have to either pull it off and regroup, Or they can say, oh, well, that's an easy fix, da 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 da. So they provide all of that stuff. So it's a lot. It's a lot, but it's good. It's good. And it's a to me, it's educational because you learn a whole bunch about, again, how something can change the trajectory of some other things, and making sure that you stay abreast of that and on top of that. So it can all be so simple, right? With the right advocacy, the right code structure, and professionals like you at the table. And one day it will be. One day soon, it will be. So thank you. Oh, we over time. Thank you for spending your Saturday morning with us. Thank you for investing in your professional growth. And thank you for caring enough about this work to keep learning. I'm Clarice Warner, the girl with the pearls, with my co host, the coding nurse, reminding you that when we lead with knowledge and integrity, we can navigate any challenge. So remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend. Keep abreast of all of the things, and we will definitely touch base again next week. All right. Thank
All
you.
right.
Bye.
Bye-bye.